Welcome, guys. Thank you very much, Sam. So, this is called knee and hip imaging, and when scans can change the game. And I am Sherif El-Tawil. I am a orthopedic consultant. These are details below. If anyone wants to get in contact with us later, please feel free. Um, so, I'm a consultant at London Northwest University Healthcare Trust. So, this is the northwest patch of London, and I've been there for the last what is that, 8 years now, believe it or not. My subspecialty is knee and hip surgery. I'm the lead for patient-related outcome measures with regards to total knee and total hip replacements. My private base is the Circle Clementine Churchill Hospital in Harrow and the Sign Clinic in Brentford. And the NHS unit in which I work at Central Middlesex Hospital has actually become the elective centre for orthopaedics for this whole part, northwest London. So we do hip arthroplasty revision. I also do hip replacements. But my main focus is on soft tissue knee surgery, including ACL reconstruction, meniscal repairs, ligament reconstruction, and cartilage preservation techniques. So the content I aim to cover quite a bit. Why imaging is important, when to scan, when to escalate, or when just to pause, and how to choose the right scan. And mainly, we're going to learn most of this through case studies. So there's quite a lot of case studies we're going to go through, and I'd love to hear lots of questions at the end. If there's any burning questions in between, feel free to put your hand up, and if I can figure out how to get to you, or Sam can help me with that, then I will, of course, let you question me as we go if you wish. So let's start with why imaging matters. Well, it obviously refines diagnosis. You can only get so much from the history and examination, although we won't underplay that. It's obviously the best part of what we do in medicine is the history and examination. And actually, there are some times where I discard the MRI results on the basis of the clinical examination and history. So we're not going to underplay the history and examination, but obviously it is somewhat limited without images. Um, it also avoids under and over treatment. So it's very common to keep on going with a treatment thinking it's going to work. It doesn't really pan out well, but you keep persisting. And that really is under treating when you could have scanned early and learned a lot more early on. But there's a balance to be struck because you could also overtreat. Like I said before, you could scan so many people and you're going to find so many things which aren't actually relevant to the patient. They're incidental findings of no clinical consequence. So we also have to be diligent about scan results and pairing it with what's going through our mind clinically. And the greatest use is in unclear cases, cases where they come in with, generalized knee pain, for example, and you really haven't got a clue what's going on. You've persisted with rehab or conservative measures and nothing really is working. So unclear cases, very beneficial. Complex cases, it's a must. And you'll see some cases later where, we need things for surgical planning and other matters where, we need further detail. So the tipping points, when to scan. So obviously when there are red flags, so if you're dealing with a patient with, lumbar spine problems and all of a sudden they lose the bladder and bowel function, of course it's urgent then to get a lumbar MRI to exclude quadratic equina syndrome. And so, there are obviously some red flags. If you've got, huge ligamentous instability in an injured knee, then of course that's, a necessity then to progress to MRI. Persistent pain. So like I said before, if patients they're just not responding to conservative treatment, then you have to go on to the next level, obviously, of scanning. Or there's something deeper. You don't think it's a superficial soft tissue injury. You think it's something intra-articular within the knee, for example. Then of course there's only one way to image, and that's the MRI. So what about escalation? When do you escalate? So failed conservative care, like we've touched upon, any ligamentous or meniscal injuries, which are pretty obvious, then you'd wish to proceed pretty quickly to imaging. And as I mentioned earlier, also surgical planning. But it's also important, like I said, not to go excessive either, and you have to know when to pause. And if patients haven't got any specific pain, you're not particularly, deep down, you're not worried about anything in particular, then there is no strong indication to proceed with the scan. You've examined, the history isn't I think everyone knows here what I mean by that. You've taken a history, you really can't put your finger on it. You examine, very reassuring examination, then you can wait. There's no sudden rush to do anything. Early degeneration, patient maybe, let's say 55-year-old, a bit of arthritis, a bit of clicking in the knee, mild to moderate pain, not significant enough to proceed with any form of intervention apart from rehab and muscle strengthening and weight loss. Then there's not really need to proceed with imaging because it's not going to add to or change your management and overuse injuries. So, how do you choose the right scan? I think most people will know, for X-rays are best used for bone alignment generally. If you want to know the hip, knee, ankle axis, then a long leg alignment view X-ray is what you need. And obviously, people with osteoarthritis, it's the best way to actually create the osteoarthritis. So MRI is useful when you can't see full cartilage loss, and you're pretty much convinced there is. But actually, X-rays are more than good enough for osteoarthritis. And in fact, we do see lots of elderly patients referred straight with MRIs, and I just don't even look at that. I just send them for an X-ray, and then if it's very severe arthritis, I don't look at the MRI. If there's not much on the X-ray, then yes, it's worth proceeding with an MRI in those cases. So MRI, as I'm sure all you know, is for soft tissues. It's for meniscal injuries, ligaments, and of course cartilage lesions, including osteoarthritis and those milder cases that aren't obviously detectable on X-ray. And then when do we use ultrasound? Well, that's for the best thing about ultrasound is obviously a dynamic test. So if something is undetected on an MRI, then you may be able to detect it on ultrasound, especially if it only appears on movement. So obviously for tendons and ligaments, but also it tells us how much an effusion is inside the knee, and at the same time you can intervene in the form of injections or aspirations. So what about CT? CT, once MRI came out, lots of CTs weren't really required, but we still obviously use them in several cases, and especially in trauma situations where we want more information than an X-ray in terms of preoperative planning of a fracture in 3 dimensions. And I also use it for rotational alignment. Sorry, alignment spelt wrong there. It's particularly useful, say, after a knee replacement that could have been done elsewhere, and you want to get, the X-ray looks absolutely fine, but you want to know about the rotation alignment, and so you can compare the hip to the knee to the ankle to figure out if that's an issue. So, like I said, majority of this presentation has to be case studies because I always get feedback that I think this is the most useful, and also, well, I think a lot of you will have seen patients like this. So most of the time, actually, I'm going to ask some questions. So be prepared to unmute. I'm not going to bite your head off. So feel free to get engaged, and let's have a two-way conversation in this. So. I'm going to start really easy. So this is obviously a football player who's twisted his knee, felt a pop, immediate pain and swelling, and he comes to your clinic, and pretty quickly, maybe 2 days later, when he thought things were going to improve, but actually nothing got better. But it really is too swollen and tender for you to actually assess properly, and you can't really, the history is that of an ACL rupture, but you can't really tell. Um, so, what we do in these situations is if we think it might be an MCL injury, we'd brace them and tell them to come back 1 or 2 weeks later for a clinical examination, or get straight MRI if that's if the suspicion is that high. But yes, say the clinical suspicion here is that of an ACL tear, a meniscal tear as well. And then obviously you get an MRI to prove that, and then you'd refer on for ACL reconstruction, especially if he's a young footballer. Second case study is a basketball player. He's 16, and it's actually over a year ago since he injured his knee, but it's a very late presentation. And this is someone I just saw last week. It's the typical scenario. It's like, why didn't you come when you injured it? But the younger generation, especially, just want to crack on and get on with things. And then things do obviously settle, and they think nothing of it. But 15 months later, he comes because he started playing a new season, and there's a bit of a pain and instability, and that's what he describes. And on examination, that's substantiated with mild effusion, tender in both joint lines, and slightly lax anterior posterior draw test. So what are people thinking here? What could it be? He didn't present 15 months ago when he actually injured the knee, but he did pretty well afterwards to an extent where he was able to return to basketball. So while I have some water, any takers, any what are people thinking in terms of injury here?
I would want to know if there's any like locking, catching, giving way, any other kind of signs of any instability as well.
Excellent, very good, absolutely, well done. So no locking, but feelings of instability, yes. What were you getting at? What was the thing in the question in the answer there?
I think I'm hyper aware that they're 16. So there are other things that could be going on, especially if there's any bony issues. So I think I would personally have a low threshold for a 16-year-old like this to image. And also I'd probably go MRI instead of X-ray, so you don't dose them with radiation you don't need. But I would, yeah, I guess the easiest thing would be meniscus that you'd want to rule out, but I would want to rule out some of the red flag nasties from pediatric side of things.
Absolutely. So that's really good. Well done. That's exactly the thing. He's a young boy. He really didn't want to present a year ago, and the fact he's presenting now means there must be something wrong. And so there's no point messing around. Go straight to X-ray and then MRI scan. And the reason I tend to X-ray these patients is actually, he's 16. It's very, low dose. It's not an issue. And sometimes you'll find things like osteochondral fragments and hemarthroses and other things. But you're right, you could go straight into an MRI. And here's a sagittal view, a side view, which shows a classic. Does anyone, before I say what this is, just so I can gauge the MRI knowledge of the crowd here. Anyone know what that shows? It's a midsection MRI sagittal view T2. So it's a double PCL sign. So the you can see actually at the back. I don't know if you can see my cursor, but at the back there is a black rainbow. That's the PCL, but in front of it is a second small rainbow. Sam, can you see my cursor?
I don't think I can see it.
No. Okay. Let me see if there's a pointer here. There it is. Aha, laser pointer. Right. So everyone see
Yeah.
that pointer now?
Yes, yeah.
Yeah. So this is the PCL. And this is a bucket handle tear of the medial meniscus. So we actually call it a double PCL sign because it looks like two rainbows. There should just only be one, the PCL, but you've got this copycat, and this copycat is actually a displaced medial meniscus. So this poor guy has actually injured his meniscus a while back and displaced the fragment into the notch here. And that's why it's really been a persistent kind of thing and why it's come to haunt him. So um, I'm going to go on to basically repair that. But what else has he got in or the lack of on the sagittal view is an ACL. So there should be a nice firm ligament here, the ACL, in a diagonal fashion, which is not there. And in fact, you can see just a very flat, unhappy stump there. So he actually has had an ACL and a complete ACL rupture and a medial meniscus bucket handle tear. And it just goes to show how prolonged some people can take before presenting. Okay. But it's more about the person and their character as well in terms of threshold to scan. This guy doesn't complain easily, as you can see. So he needs an ACL reconstruction and a medial meniscus bucket handle repair. Okay, let's do some other type of questions. So 69-year-old lady, hip pain, it's about a year and a half. It's increasing, can no longer sleep on the affected side. When you actually examine her, she's got good range of motion in the hip, but she is tender over the greater trochanter. So what do people think it could be? This bit gives it away. No longer able to sleep on that side. I'm just going to see if
Trochanteric pain syndrome.
That's right. Very good. Absolutely. And someone's written bursitis. Well done as well, Rebecca. Right. So absolutely. So what would you do? What imaging would you do? So the examination gives it away, because actually the hip itself is pretty good. And actually she didn't complain of any groin pain. Okay, so I'm just going to go back to chat because it keeps going away and I can't see the comments. So let's see, beside MRI to check for degenerative tear. Okay, so I think that Max is talking about a degenerative tear of the labrum. None. Okay, none if no conservative management to date. Very good. All right. So ultrasound, I won't say any imaging. Okay, so that's great. You can see the breadth of opinion here. Okay, but what I would say is it's gone on for a year and a half, and she can't sleep any longer. So I think. Of course, I should have said she's tried, rehab and physio and abductor strengthening. So that is something that would affect management. So if she hadn't had any rehab, yeah, you're right. There's no need to intervene now. She's had it that long. If she hasn't had physio, it's definitely worth referring her for abductor strengthening, and to rest it. But what I was getting to is what Lizzie, I think, has just posted. Ultrasound and consideration of steroid. Exactly. So rather than MRI or a hip X-ray or something where we know the hip isn't a problem, and even if it was arthritic, it's not her issue. Her issue is the greater trochanter. Then proceed with an ultrasound of the greater trochanter plus minus injection. So what I do on the report is I say, please image the trochanteric bursa and proceed to steroid injection if inflamed, which obviously most of the time it is. So it's 2 in 1. It's low-hanging fruit. You make the patient better, you get the scan at the same time. And of course, if there is any query about the hip, easy, X-ray. And often it will actually be hip arthritis that drives this. And it is worth exposing that earlier on, so you've got a baseline X-ray. So well done, team. That's the ultrasound that none of us can read. Only the person developing it, actually performing the scan, is able, because this is just one screenshot. It's very hard to understand that, but you need to be the operator. It's very operator dependent, obviously. So case 4, 17-year-old girl who fell on concrete. Sudden large effusion and anterior knee pain. I'll give you a second while I drink again to think about that. What could this be? And of course, there's lots of differentials. Okay, so let's hear a few. Bursal irritation, very good, yeah. Prepatellar bursitis, patella, yeah, could have fractured a patella, absolutely. Very good, because it is a direct impact. So, and often, if you were to MRI these patients, you do find inflammation right at the front of the patella. It's not actually bursitis, it's just the impact site. And sometimes you can have bony bruising. And so what would we do first? X-ray or MRI? Yeah, X-ray. Nikki's right. That's what I would do. So here's the X-ray. Does anyone see anything? So I'll give you a clue. It's on the lateral view. Avulsion. Very good. So it could be. So you can see something here. Okay. So apart from avulsion, what else could that be? So by avulsion, I'm assuming you're meaning quadriceps avulsion from the proximal patellar pole, which is possible. So what it could be is an osteochondral fragment. And actually, this is remarkably, absolutely, Phoebe, OCD, so osteochondral defect. So it's probably because I'm a soft tissue knee surgeon. I see a lot of kids with osteochondral fragments, and I pin them back. So obviously, I'll get an MRI once I've got this X-ray, which looks suspicious, and prove it. And it always looks bigger on my MRI because of the cartilage that's attached to it. So often they can be quite large, and it's a very satisfying procedure to pin that back surgically. And in kids, they honestly take so well that they become symptom free within weeks, and I never have to see them again. Obviously, there's always a risk, especially if it's a chronic injury, that these things can fall away and collapse and not take. But the more bony the base, the more likely it is to heal and heal well. So Actually, very satisfying operation in terms of cartilage work. So well done, guys. That's great. Great case. Case 5, 70-year-old lady, bilateral knee pains. She's had it for several years. And now the left has actually overtaken the right. It's become an issue. So what's the modality people would do here? I think this is pretty easy. Yeah, someone's thinking OA. Absolutely. Absolutely. OA as well. Absolutely. You're getting there. So what's common is common, correct? So it's a this is what I was referring to earlier. We do see lots of MRIs in this age group, which isn't really warranted. That you just need to do an X-ray, and here she unfortunately has a very severe valgus deformity. So mostly lateral and PFJ osteoarthritis, and she needs a knee replacement. So that was a patient of mine who I did an osteotomy on, and I couldn't find his X-ray, so forgive me. But he was very happy for me to put him in the presentation, but I just couldn't find his X-rays. So anyway, case 6, 48-year-old man, 2 weeks of knee pain without any trauma, and the clinical examination isn't very significant, except he's got some small scars around his knee, which he didn't mention. And the thing is, he had that surgery abroad from where he was originally from, and he can't actually remember what they did, not in any way. And so, he's only got a 2-week history of pain. You're seeing him in your clinic. There's no history of trauma, so nothing particularly worrisome. But would you do anything, or would you just, rehab him initially and think about scanning later? So some people say X-ray, some say wait. Has he had rehab? No, he hasn't. This is the first presentation, so he's not had any rehab yet. And so, it's really interesting to see as allied health professionals how you would rehab and wait. Where we in hospital, obviously, we have X-ray around the corner, and our threshold is is a lot less. But we're privileged in that way, and maybe overexposing people in that way. Who knows? But unless any concern about infection traveling recently, no infection, no recent travel. When is the pain occurring? I have to remember this guy. It's on motion, it's on weight bearing, and particularly on stairs. But it's actually throughout the knee. It's very hard. He doesn't really give a good history. He's got generalized pain. So anyway, I did an X-ray, and the reason I did an X-ray immediately with him and not rehab him first is because actually I wanted to know what surgery he had, because it is relevant, and he just couldn't tell me. And we can tell from this that he's had an ACL reconstruction. So you can see the tibial tunnel there, which is quite wide actually, maybe even cystic. You can see almost near the tibial plateau a cyst, and he's got a staple that holds the graft as well. You may also have a bioabsorbable screw in the tibia. We just can't see it. Same for the femur. So immediately now I know I'm dealing with a patient who's had an old ACL reconstruction, but for his age, he's actually got some degeneration going on there, which is actually really common for those who have had ACL reconstruction many years ago. Sadly, the natural history of an ACL injury isn't cured completely by an ACL reconstruction, but somewhat delayed in terms of progression to osteoarthritis. So could that be secondary OA? Tony asks. Absolutely, and that's exactly what it is. And it's one of the reasons I did an X-ray immediately on him, because A, I wanted to know his surgery, and B, the consequence. What's happened? Could it be linked? And in this case, it's definitely linked. His osteoarthritis is linked to his ACL injury many years ago. So case 7, did he not have any laxity on anterior draw testing? No, he didn't, and it's because he's got osteoarthritis. So it's interesting how these kind of patients go from being very lax, then having an ACL reconstruction where things improve, then going back to football and doing whatever they want to do for years, and gradually becoming more lax, because these things never last forever, unfortunately. And then they end up having secondary osteoarthritis, which makes them stiff and hides any laxity. So great question. Any other questions on this before we move to case 7? So, case 7, a 74-year-old lady with bilateral groin pain, severe, and back pain, but it's mild, moderate, not as bad as her hips. So modality, X-ray. I think everyone's agreeing with that. Yep. So X-ray is definitely the right thing. Again, on the premises of age. And guess what? Not only do we see a very, very bad osteoarthritic right hip, which is almost fused into her pelvis, but we've got osteoarthritis on the left side, but not as severe. And the reason I've shown this is because she had similar pain on both sides. And we know, X-rays and MRIs don't always, correlate completely with patient symptomology. And this is exactly the case. So despite having bilateral groin pains, the right is far, far worse than the left. And guess what? She's also got some lumbar stabilization going on here. So we have an explanation of why she may also have some back pain. But the focus here is the hips, because that's what she presented with. And of course, back pain, well, can only be cured to some extent. Typical hip and knee comment. And I did a right hip replacement, and she was very happy. And subsequently, the back pain also resolved because she was walking better without a Trendelenburg gait. So that's a nice straightforward case. Okay, case 8. 17-year-old girl playing netball and felt her kneecap pop. And she had immediate effusion and pain in the knee. And again, there's going to be a few differentials here. So let's hear it from the crowd. Let's hear if you've got any ideas of what this poor girl may have injured. So she's playing netball. She felt a pop as she twisted and an immediate effusion and pain. Yep, so we've got quads and patellar tendon rupture, patellar subluxation, differential diagnosis, ACL and meniscus. Absolutely, it could be any of those, okay? The first thing that comes to my mind in this kind of age group is patellar dislocation. So that does cause immediate effusion, but well, so does an ACL rupture. So what would we do in terms of modalities? Yeah, exactly. X-ray and MRI, but I'm going to jump straight to MRI because their X-ray was normal. So this is the axial view. That's a shallow trochlea. It should be deeper and more V-shaped than that, and that's why her patella is tilted laterally, tilted, subluxed. Laterally, it's almost perched really on the edge of that lateral femoral condyle. And you can see the bone bruising here, and the corresponding bone bruise on the patella. So if that was kissing that patella was actually sat here during the dislocation. The medial facet glows on the MRI, and so does the lateral femoral condyle. So that was actually in contact with that during the dislocation, and she had relocated spontaneously. And unfortunately, she's lost half of the cartilage behind the patella. So a huge, huge defect here. So you can see how on this side, the lateral facet of patella has its cartilage, but the whole medial facet here is really been disrupted. So again, satisfying procedure, as mentioned earlier, pinned back the patella fragment, and also at the same time did a patella stabilization. Ouch, exactly, Lizzie. MPFL reconstruction, absolutely. So there's me putting a guide wire into Schottle's point to find the isometric point of the MPFL. And I used to use a hamstring to tie the patella down to this area, but now I use actually a synthetic tape. Patients do just as well without the donor site morbidity of hamstring harvest. So and actually, they're often very happy, so happy they beg me for the other side. But I have a policy: if there's no osteochondral fragment and there's no history of dislocation, then unfortunately not. So I kind of wait until they dislocate to be to clinically allow that contralateral side to be operated on as well. But often most of these girls will have had recurrent dislocations on both sides, and once they know how nice it is on this side, then I go on to do the other side. Could that be because the patella wasn't sitting correctly in the groove beforehand? Right. So very good question. I see tons of kids with this problem, and it's many factors. The most consistent factor amongst all these patients is a shallow trochlear groove. So you can see here it's shallow, and therefore the patella, no matter really how strong the quads it can become, will always be easy to be pushed out laterally. Okay, so this is the primary issue which I see in most people, but I don't rush to deepen that. There is an operation called trocheoplasty to deepen that, but it really is quite invasive. You have to basically cut open the cartilage like a trap door curette some bone out from beneath and then flap the cartilage back. So it's quite traumatic to cartilage. It is indicated and used in particularly severe cases, especially where MPFL reconstruction may have failed. But MPFL is, to me, a low-hanging fruit operation. If the patella isn't, too high and it's not too lateral on the, the tibial tuberosity is not too lateralized, then it's a very good procedure. Obviously, as I said, there are other factors. So if the tibial tubercle is extremely lateral, so let's say over 18 millimeters TT to TG distance, the tibial tuberosity to trochlear groove distance, if that is markedly over 18, then I'm more, and you've got patella alta, I would transfer the tibial tubercle, I'd move it distal and medial. And that will often get rid of the problem. So you often try and address the problem, but most of the time it's just a shallow trachea where an MPFL reconstruction is enough. Okay, could that be because absolutely. So hard to rehab, yes, absolutely. And it goes back to what we're saying: is when do you escalate? When do you start to scan? When do you start to pause? Because if you've got a young girl who hasn't had any serious trauma, but is subluxing laterally clinically, you J sign positive, all the symptoms and signs, may have had a significant subluxation, but not really a dislocation. You don't need to image it. It's going to be quite obvious what's going on, and those are the cases where you don't have to rush to imaging, and you can rehab. And you're absolutely right; they are tough to rehab, and there's only so much you can do to get the VMO back, the vastus medialis obliquus. And in those situations where you're just not making progress, that's when you escalate and scan and send to me if it looks like this. Because it's a shame most of you won't get images. I think most of you will only have access to reports. Although on scan.com, I think you do get images. I certainly do. Sam, any comment on that? Does everyone get images if they order from scan.com? Because I think GPs are at a big disadvantage in the NHS where they just get reports and they can't see the images. I think as clinicians, we all want to see pictures because it gives us something to show patients, and B, to put a handle on things. And well, if you're clinically interested, it's a great benefit. And I think scan.com does give everyone the ability to look at images. So
yeah, that's correct. Yeah, so
yeah.
we do give our clinicians access to the images. As long as they're referring through the portal, you do get access to the images. And if you don't get access, to contact us. But yeah, you should always get access to that as well.
That's great. That's, I think, hugely beneficial, and actually something, as I say, in the NHS, GPs unfortunately can't access, well, not easily. We are fighting to keep ours. Liz, what do you mean we are fighting to keep ours? In terms of images, or patient can share their images?
So I work in community outpatients in MSK. So we have two places patients get scans. So one's a local hospital and one we can refer to that's probably similar to scan.com. So if we refer, we can get those images absolutely fine. The local hospital is moving their systems over and they're not going to be sharing it with other people essentially because of money, I think. So we're going to lose a lot of the GP ordered ones, but if we order it, then we can see it. So it's just going to make potentially more people cost more to have repeat scans if we need them. But it's really helpful for me to see the images and teach using the images as well.
Absolutely. It is absolutely, yeah. It's so important to give. You could explain it all you like, but when you just show how flat the trochlear is and how big that defect is, you can't put it into words. So I'm with you, and it's a shame that it's not more accessible. And I hope you retain what you're able to retain. So I stabilized it, and I think I've done the other side as well now. So like most patients with patellar instability, it's bilateral, and in the end, they both sides will need doing. Right, case 9, 59-year-old lady, long-standing anterior bilateral knee pain, and yeah, it's unusual, isn't it? Because normally we get, as I say, young girls with the bilateral anterior knee pain, but this is a 59-year-old, and it's long-standing. So what are people thinking, and again, what modality would they do? I think most people know it's X-ray, right? So here we are, X-ray, and again, it's funny what patients forget. That they had this patient's had an ACL reconstruction on the left side previously, and again, secondary OA. You can see the osteophytes, the minimal joint space, but also there is some some osteoarthritis on the right side as well. So it's not, you can't blame the lack of an ACL previously only for that. So there is some native osteoarthritis there. And on the laterals, ACL position looks fine in terms of its exit on the tibial plateau. So these are some things we check on all ACL patients, just make sure the ACL reconstruction was done right. And then the patella, you can see the patella isn't shaped correctly, and there's osteophytes actually on both sides. A very strange one on the right, actually, with what seems to be quite a little shark bite out of the middle of it. So so I'm thinking, okay, so she's got osteoarthritis. I don't know why she's just got anterior. The tibiofemoral joint is affected on both sides, and more so on the left side. So why has she not got joint line problems and weight bearing problems? It just seems to be more anterior. And then I do an MRI scan in that case, because the previous X-rays are not enough to justify a knee replacement. So what is the next step? Again, most of these cases have already been through rehab, and they've been through all of this. And potentially injections. I can't remember in her particular case on yes or no. But when I've got X-rays like this, I do progress to MRI, because it's kind of in no man's land. I've got arthritis, but not sufficient to warrant surgery. So do I discharge her with a plan of just rehab and plus minus injections, or are we doing her injustice because she has no cartilage at all behind the kneecaps? This is shown here. So you can see how deceptive X-rays can be. This is a case where they look like there was joint space on the lateral views, but and there is joint space, but to us, that a very flat looking retropatellar bone, and here it looks like there's something going on here. So that's when I've got suspicions like that on the images. I then proceed to MRI to know exactly how much cartilage, and actually she's completely devoid of cartilage on that side, and she's got a little sliver left here. So she has really quite significant osteoarthritis. So actually it'd be pretty harsh if she was in severe pain and already tried rehab and physio and quads exercises, and to kind of banish her to just injections. So all of a sudden, replacement surgery becomes an option, especially if she's really, really struggling. So, and obviously, if she hadn't had much physio or much in the way of conservative management beforehand, then absolutely go back and continue and see me in 6 months with a view to escalating if needed. So it's a good case where X-rays sometimes don't reveal everything, especially in the elderly. So case 10, 69-year-old lady, previous left knee replacement 20 years ago. So it's been a while, but it's only been painful in the last year. She was okay up until a year ago when she started getting weight-bearing pain. So what do people think this could be? Check her hip. Very good. Very good. That's absolutely right. So don't just assume it's the knee. Radiation from the hip obviously can be an issue. So that's a great comment. So these are X-rays. So she's actually had bilateral knee replacements previously, but the one in question is the left knee, which actually, despite it being a very strange prosthesis from long ago, and you'd really think it was edge loading on the tibia here, doesn't look loose, because 20 years of a good knee that then becomes a problem could indicate loosening of the prosthesis. But this X-ray looks fine, and the lateral looks fine. In fact, it looks like it was done yesterday on this one. The patella's also been resurfaced, which is good. There's a bit of ossification here at the insertion of the patella tendon on the tuberosity, but it's a red herring in this case. There isn't anything going on there. So we've got a reassuring X-ray. So what would we do next? She's still got pain. We've done a hip X-ray. I'm sorry, Lizzie, I can't show you, but it's fine. There's nothing on the hip. She's okay at the hip, but a normal X-ray. And she's a good historian. And again, it's been a year, so something definitely is going on. Very good, Max. SPECT CT scan. That's absolutely right. So that's exactly what this is. right? So you want to check for loosening, you want to check for an infection. Say she had some dental work and all of a sudden that spread some bacteria to the knee. It should show up. Now, some people don't like SPECT CT scans because it could be ambiguous. But to be honest with you, I still think they're quite useful. I use them quite a lot in my knee and hip replacement side of things, because if you've got an old prosthesis, you're not sure it's loose, the x-rays are fine, then you look for things to glow. So these are radio active contrast, basically, that is injected and taken up by the bone preferentially where there is more activity. And a CT base is laid onto that, onto the images. And so you get a lot of information, because if things glow markedly, there's a problem. If it glows early, it tends to be things like infection or increased blood flow. If it's a bit later, it could be loosening. So a SPECT CT scan can help you differentiate. It can detect a problem. Here you can see the right knee lights up a bit, and so does the left side. This to me is normal bone stress response from the metal, as it interfaces with the bone. So what I'm showing here is actually no significant increased uptake. If it was, it would be 3 or 4 times as bright as that yellow patch there, and it will not just tell you there's a problem, but tell you where the problem is. So say there was a hugely active spot below the tibial plateau, it's the tibial plateau which is loose and not the femoral component. So SPECT CTs in my practice, I do use them, I do like them. Of course, they're not everything. Just because it glows doesn't mean there's a problem. For example, in this patient, you can see the left knee was a problem, the right knee she's very happy with. But if you had to choose which side lights up more, you'd say it was this one. But to me, again, this is just normal bone stress response to the implants rather than a significant problem. So that's that case. So actually, it's a difficult case. She wants something done because she's actually really struggling with this now, and it may be I will come to revise that to a revision prosthesis. But we really don't like doing that in cases where we cannot find the issue. Her blood tests are fine. There's no infection. There's no obvious loosening, let's say. But sometimes we according to the pain levels, we have to do something and operate. So I think she is going to have revision surgery, and the outcomes of revision without a known source of problem is dubious, and we have to let patients know that. But when pain is really getting to them, there's little other choice sometimes. So case 11, 70-year-old man, right knee pain, 4-year history, and of course we're going to do an x-ray. I think you've gathered the pattern here. And does anyone recognize what's happened on the left side? What operation they've had? Yes, patella resurfacing. That's right. So this is a resurfacing of the patella, absolutely. So it's a unicompartmental, it's a partial, not your usual medial compartment. But again, this is a very satisfying operation for those with isolated PFJ disease. And she's really happy with the left side. And I thought, well, okay, if you look at the x-ray on the right, of the right knee, there is some osteoarthritis in the medial compartment. There is some in the PFJ, but doesn't look too bad. But again, you can read into the history of this patient. They've had isolated PFJ disease before. And just like the other case before where the x-rays were deceptive, this is a case where I would get an MRI scan of the right knee to see how much cartilage loss. Because again, the skyline view is very benign, looks fine. But the patient's complaining of anterior knee pain. So I basically did get an MRI, and it showed full thickness cartilage loss, and she's on my list for a PFJ replacement, and hopefully will be just as happy. So again, remember, clinical, the clinical examination is paramount, and can be only assisted with MRI. Case 12, 41-year-old accountant, previous ACL reconstruction in 2022, and actually went back to football later that year. And it did well for 3 years, but then came to see me and said, I've got this strange lump on my shin, and also a bit more unstable at the knee when I play football. So modality, I think were clear as to, the ACL would need an MRI. What about the lump? What would people do for the lump? The lump is on the shin, so this will not be caught with a knee MRI. It's further down. It's just at the mid-shin level. So the MRI, the scout view, they will obviously constrain that to the knee and say the proximal tibia. So we're not going to unfortunately see the lump. So people saying ultrasound, yes. X-ray, failing surgery, yes. Very good. Or CT if concerned, right? So Liz, why CT? Why are you thinking CT?
If it's a surgery issue, like a failed surgery, or there's something going on with the, I don't know. But if the CT, you said earlier, the CT can kind of show that rotational profile, and if you need to go back in, you can see. I don't know. It's a guess.
Yeah, no, that's great. I was just interested to see, and you're on the right path there. So it's exactly that. You want to know about the tunnel position. You want to know if the tunnel position is correct or not. You want to know the size of the tunnels, because if you are going to revise it, then you want to know if you have to do it in 2 stages, because the tunnels are so wide that you need to pack it first with bone graft and then come as a second visit to do a second stage and actually put the ACL back in. And there was something else I was going to mention. Oh, yes, in terms of what they used. So did they use a metal screw? Did they use a plastic screw, an endo button? It's always useful for that. Query malignancy. Yeah, good. So Daniel talks about that. It's very good. Always think outside the box. Thankfully, in this case, it was nothing. It was a completely benign lump. But absolutely, always think of malignancy. And especially in the young, sadly. I've had 2 kids present to me, very young. I think one was age 7. Ankle, it was a football injury. They thought in A&E that it'd broken his ankle. It was red, hot, swollen, typical, presentation of a fracture, tackled, x-rays, no fracture. But if you look at the soft tissue, sadly there was a lump. Turned out to be a Ewing sarcoma. So don't get distracted so much by the history that you only think of trauma. So absolutely, that's great. Because the MRI wasn't going to catch the lump, I referred him for an ultrasound that showed basically a small lipoma, nothing to worry about, reassured, but not reassured with his knee, unfortunately, because he had a ACL re-rupture. So he's had failure of his graft. As I said, there should be a nice solid tendon or ligament going across there, and there isn't. You've got the typical bone bruising pattern at the back of the tibia during the pivot shift mechanism. So he went on to have an ACL revision and reconstruction. I think we're coming to the end, so I'm sorry I'm taking so long, everyone, but is there any link with the lipoma? No, completely separate. So there was no link, Lizzie, with the lipoma appearing. And it just goes to show it could be so many coincidences and red herrings. It was a total red herring, absolutely, unrelated. I just used it really to show the different modalities, and don't always assume that sending someone for an EMRI is going to catch the thing that is further down, because they can be somewhat constrained with the scout, with the field that they actually look at. Okay, and that's the other thing I wanted to mention, is always be really clear when you refer for imaging, because it really helps the radiographers and the radiologists, the reporters. So because if it was close enough for an MRI knee, I would have said MRI knee query, ACL failure, graft failure, but please widen the view to try and catch the distal lump, which is about 7 centimeters distal to the joint line, and that really helps them. So the more information you give the radiologist and radiographer, the more you're going to get back in terms of result. But if it's obviously too far, then go for a separate modality. Or MRI tibia as well. I add the MRI tibia, but wherever you can do a cheap, cheerful, and quick ultrasound, it's often beneficial. So 50-year-old postman, anterior knee pain, particularly on stairs. X-rays are normal. Does everyone see anything here? So this kind of is a distraction, because on stairs you start to think about PFJ osteoarthritis, although he's not quite old enough really, but could be. But the x-rays are normal. So this is what I was showing, patellar tendonitis. So you can see the the patella tendon being very thickened and edematous as it originates from the patella there. And this is an MRI scan, but you could equally have got a ultrasound. So Tony, absolutely yes, patella tendinopathy, quite severe on this one as well. So again, this could aid in your management because there is a big difference between a slightly inflamed patella tendon and one that's this thickened and chronic and looking really quite nasty that it might need further intervention and escalation. 42-year-old cyclist, direct knee blow, unable to weight bear, x-ray looks fine. What would you do next? I think most people are thinking MRI, but in this case, because of the trauma and the fact that he actually had a direct blow to the knee, actually had a CT scan. So you can see the tibial plateau being depressed here. And it's always quite shocking to see scans like this with a normal x-ray. You think, well, how on earth is that the case? The x-ray didn't show the depression. So you can see here, I mean, this isn't, you know, hugely depressed, but depressed enough for us to do something and fix it. And here's the open reduction internal fixation, screw and plate, nicely restored joint line, bone graft to hold it up. So that's where CT actually is useful and what we use in preoperative planning. This may be the last one. Where was the blow? Oh yes, the knee. I have a numerous tibial. I've not seen x-rays. Yes, absolutely. So someone's commented, I have had numerous tibial plateau fractures not seen on x-rays from A&E and called back after. Absolutely. It's really, really common. And you know, the depression of the bone here is actually more than you would see in some others. And still it's important because obviously you can't tell this patient to weight bear. So there are some cases where you think actually maybe because the x-ray was normal, they were told that it's all fine, the weight bear, and then it becomes depressed. It's hard to know if it was depressed at the time and the x-ray just missed it, or it's because of what happens in the days that come after the presentation to A&E. So unfortunately, it is common, and this is where clinical acumen comes in. If a patient is trustworthy and really complaining of severe pain, and the ligaments are stable on stressing, but there's an effusion, you know something's going on, so you don't trust the x-ray. You do escalate. You either get a CT scan, which has the benefit of being quicker. Okay, you know, MRIs often you have to wait a few days, even as an urgent one, whereas a CT can be done same day, next day, to get straight to the diagnosis. So in trauma, CT is particularly useful, especially to save time, and if you haven't got time to wait for an MRI. The only caveat is you don't get any information on the ligament. So I've had a few patients, not many, most people have just got the fracture, but some have got concomitant ligamentous injuries like an ACL rupture and a meniscal tear, which would be nice to address at the same time. But often what really happens, especially in the NHS, is that you deal with the fracture and then assess everything after that's been fixed, and then we can deal with an ACL or meniscus later. But very, very real comment. Thank you, Liz. 72-year-old. She had a fall, then she had groin pain, difficulty weight bearing. She could still walk, but it wasn't easy. An x-ray, well, didn't reveal much, to be honest with you. So these are the cases where the gold standard actually is an MRI. You know, we used to CT these patients, but you know, especially if they're presenting to A&E, we would try and get this is probably the fastest you can get an MRI along with chordae equina to exclude a fracture, because even CTs aren't sensitive for neck and femur fractures. So this is something from the BMJ actually, where it's a great series that shows a pretty much normal X-ray and a normal CT. Even the trabecular pattern doesn't even look disturbed. It's remarkable. But the amount of edema is extremely suspicious. And then here you can see a cortical break superiorly. So was stabilized with the DHS. So this is gold standard. This is how it should be. But you know, sadly, MRIs are not so easy to get. And so luckily, if you're in the private world, you can get one quickly. But unfortunately, in the NHS, it's sometimes delayed. We would actually, if my clinical suspicion was that of a neck and femur fracture in an old lady, I would go straight to MRI. I wouldn't CT, especially if I know I can get that quickly. So, imaging pitfalls. We've said about overscanning. You can find lots of stuff, okay, and especially in the spine. I'm a lower limb surgeon, so I haven't talked about spine, but it is, you know, you image my spine, you'll find lots of problems. So it's you always have to clinically correlate, but also we can't be too extreme in the other extent by underscanning and actually missing things and persisting with conservative management for too long, which is something I tend to hear in secondary care, tertiary care, sorry. That, you know, oh, I told blah 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 that, and you know, it just kept going and going. So there has to be obviously some balance, and reading the patient as well, their personality and knowing what they're like really helps. So you have to balance clinical suspicion with some evidence of a problem. And the practical takeaways are always start with a good clinical exam. Like I said before, it's imaging is just for helping it. You can't use it on its own. Choose the right scan at the right time. That gives you the right diagnosis. And collaboration across professions improves outcomes. So I'm very happy to speak to allied health professionals. All the physios know me very well at my hospitals, privately and in the NHS, and will often just call me up. So that's why I put our details here. If you ever need to ask me for any advice, I'm more than happy, and even happier now to take questions.
I have a question if you don't mind.
Sure, go ahead.
With a subchondral fracture, I had a lady recently have an X-ray from GP before they'd seen me, and it showed a healing subchondral fracture. She was doing 15,000 steps a day. It was still a little bit swollen, but she was really fine. But the GP had already ordered an MRI. And I spoke with some of my seniors, and they said, yeah, if you know, pain's not stopping her and it says healing, you know, carry on loading. The MRI came back 3 months later that it's still showing a subchondral fracture. I've not been very happy. I've then had to call her and say, I'm sending you some crutches now, get off that leg. And I think for me, I wondered if, firstly, how that has been so different on 2 scans and also her presentation. I know it's never black and white, but for me that I'm quite a junior physio, or I've just just got senior role, but it scared me.
Yeah, sure. She had 2 MRIs or 1 MRI?
So she had an X-ray that showed healing subchondral injury,
Right.
which was about, I think, a month after the injury. It was a really non-severe injury. It was a very slight twist.
Yeah. How old is she, roughly?
She was in her 60s or
60s.
maybe.
Okay.
And so
Yeah.
I was like, that MRI is going to show everything.
Yeah. And
Yeah.
that's this is exactly what we were saying earlier. So if she was doing so well, maybe there was no need to progress to MRI because it just can actually complicate the management. Bone subchondral fractures are just bone bruises, okay? So they're not significant unless there's depression, which is very unusual. So if a patient has no trauma or very low energy trauma, it often will be a bone bruise. And the reports are really scary. We get this all the time. Patients go, "Oh my God, I've received a report that says I've got, you know, significant subchondral fractures." Now, when you actually look at the images, and this is where it's really beneficial to look at the images, you'll find the cartilage is actually absolutely fine. There's no depression, there's no disruption. It's just literally bone edema below that. So trabecular microfractures is the other way they can report it, trabecular microfractures. And so that is a bone bruise. And that will show on an MRI for a very long time. You know, it's really interesting about bone bruises because there's not much research about them. They can persist on MRIs, in my experience, for 1.5, 2 years. I have a patient that still has a bone bruise, and I keep having to reassure them, I'm not worried, because clinically they're fine. Whereas there are some patients who the bone bruise on an MRI will disappear after 3 months. So it's a really interesting phenomenon. But again, treat the patient, not the scan. So I think you're right to persist, just carry on. And in fact, there's if the patient complains of pain, then yes, provision of crutches will accelerate the healing of these subchondral fractures. Okay, but again, I personally think from a structural or strength point of view, just because there's some edema on MRI doesn't mean you have to non-weight bear them if they're pain-free.
Yeah, she's not pain-free anymore. That's the thing. She was, and then it started to flare up.
flare up again. Well, that's a bit unusual without extra trauma, you know,
Yeah.
unless she's quite osteoporotic. That's the other thing.
So
So
that's the thing they've now said on the report. That's the other reason I got a bit worried, as they said, they suggest GP does bone density and mineral tests ASAP.
exactly.
And that was the thing that made me go, I'm gonna be safe.
Yes, absolutely. And that's right. Treat the pain or the patient, okay? And so you're absolutely right. A patient who represents, which is already a red flag, with pain, which wasn't there before, another red flag, means you will then need to crutch them, okay? So I missed the flare up, sorry, in terms of symptoms. So, and that's what I do with bone bruises. I say to the patient, here's some crutches, use them if it's painful. Try and wean yourself out, and as soon as wean yourself out of the crutches as quickly as you can. And if it takes a long time, so be it. You know, it's the patient's body will tell them better than an MRI scan as to when to start to weight bear. Okay, so I go on patient's pain. That is the crucial thing. So you did the right thing. The patient now needs a DEXA scan for bone density, and probably calcium and vitamin D to be checked as well in the blood.
Thank you.
Pleasure, pleasure. I think there's another question here. Rebecca, in the knee X-ray with the patella changes, is that historical chondromalacia? Which one so I showed quite a few. Is it the young patient? Because generally chondromalacia is a huge problem, right, in the young. And I'm sure all of you, you get that, heart sink feeling when you have a patient with chondromalacia patella that you really want to help them more, but you feel constrained and you can't. It is very common that patients see me with anterior knee pain, sometimes acute, not necessarily chronic history. And their MRI, doesn't show any cartilage defects. It shows the usual patella tilt that we looked at earlier, and softening of the cartilage, and sometimes really significant softening of the cartilage to an extent where you think we're going to have to do something soon, okay, to either realign the patella or really, go crazy on the quadriceps exercises, because it's as if it's a pandemic sometimes. It feels like it is so common and we can't do that much. Most of the time, obviously, rehab is the only way, but if they're really struggling, hyaluronic acid as an injection, it can be helpful. So, yeah, the older lady. All right. I was just wondering what the long-term effect on the knees after having it is. Yeah, well, that's a great right. So, Rebecca, that's exactly what I was alluding to. So, yes, that's the problem. Chondromalacia in the young can progress to osteoarthritis in later life. That is absolutely an issue, and I would say most of the patients I end up doing a partial knee replacement on in terms of patella resurfacing, just an isolated patella resurfacing operation, have had chondromalacia historically that they didn't do much about. It kept laterally, the friction was on the lateral condyle and lateral facet, and they basically denuded the cartilage behind the patella. And then they had isolated patellofemoral osteoarthritis bilaterally. So often they end up having a PFJ replacement and then coming back for the other side. So unfortunately, that is the natural history from what I can see. And we just can only do what we can do in terms of VMO strengthening, hyaluronic acid, and I just gave a presentation last week about arthrosamid, which is another injection which is come to the UK market in the last 1 or 2 years, which I think is going to have increasing benefit in terms of changing the pathophysiological processes through the knee. So, right, I will come and see you something. Oh, anytime, Rebecca, anytime. It'd be my pleasure. Thoughts on hyaluronic acid injection for OA versus CSI? What's CSI, sorry? Combined steroid injection? Corticosteroid, maybe. Corticosteroid injection? Yeah, it's interesting. Your acronyms are different to us in the surgical field. So it depends on age and degree of wear. Okay, so if someone For me, steroid is the last resort. All it is it's a painkiller. As a knee preservation surgeon, I want to try and preserve the knee for longer. So I always try biological treatments first if they're eligible in terms of cartilage wear. If it's not too bad, if it's not grade 4 osteoarthritis, then grade 2 and 3, I would give hyaluronic acid a try, PRP, so platelet-rich plasma, and even arthrosamid, which has now reached the market. So those are things I would try and do to try and slow down the wear so we don't have to replace, okay, if it's caught early enough. Steroids I only use as a painkiller because that's what it is, and it just reduces inflammation. So that's my thoughts on HA versus steroid. Does that make sense? What grading do you use for osteoarthritis? I know the mild, moderate, and severe subject. Yes, so I use the Kellgren-Lawrence, but that's again because I have the advantage of most of my patients have an X-ray in front of me. So Kellgren-Lawrence classification is on X-rays. It's about how much joint space narrowing you have and how many osteophytes and the degree of disease. That's what I was alluding earlier about hyaluronic acid and arthrosamid and PRP being beneficial more for grade 2 and 3 disease rather than grade 4 disease. I was talking about the Kellgren-Lawrence classification, 0 being no osteoarthritis, 4 being bone-on-bone severe osteoarthritis. That's what I use. But remember, that has its limitations. So as we've seen earlier in the presentations, just because there's no joint space narrowing doesn't mean there's no cartilage loss. Hence the need for an MRI if you are convinced clinically that the patient's suffering.
Amazing. Thank you. I just want to say a massive thank you to Sherif for leading this webinar and answering everyone's questions. I want to say everyone's had great participation and great comments.
Great, Sam. Thank you so much. And thank you to the crowd. Thank you.